talking about the joys of stroke volumes and how they're going to change with training. So what you're going to find is as you get to be in better and better condition, you're actually going to increase the amount of blood the heart is going to pump per beat. So specifically, you guys are looking across, you can see how the stroke volume of an elite level athlete at rest is the same as the stroke volume you're going to find in an untrained person at maximum effort. And so when we think about cardiac output equals our heart rate times our stroke volume, well, if you literally have twice the stroke volume of the person next to you, and heart rates, we can only go effectively so high as a human, you're going to have a massive advantage because you're literally going to pump more blood per beat. So we're going to see with training, you're going to have greater end diastolic volume. So we actually are able to fill the heart more. And then we're going to be able to empty the heart almost to the same amount of blood that would have been left over. However, what we're going to go ahead and find is that ejection fraction. So the percentage of blood we're clearing out of the heart per beat is going to increase. Now notice at rest, there's really no difference as far as that ejection fraction. It becomes more and more prevalent once we get up to higher and higher intensities. So endurance training is going to increase our stroke volume both at rest and submax and maximal exercise. We do this by increasing our end diastolic volume because we have not just a greater amount of blood plasma and a greater amount of diastolic blood filling time, which we're also going to have literally a larger heart in general that we can fill. This is going to allow it to stretch more, and when it's stretched, we're going to increase the thickness of the walls, aka the myocardium, the muscle, so that not only is it going to hit a better point of myosin cross bridging to produce more force, but it's going to have more muscle, so it can even more so produce more force. And because we typically have lower blood pressure as an adaptation to long-term training, we're going to go ahead and see that there's less resistance to pumping that blood throughout the body. And hence we are going to have even more blood per beat. Now, maximal heart rate when it comes to training isn't really going to change too much. We're going to see it maybe come down a little bit, but that's simply because now we have that bigger, more powerful heart. So if you guys are looking here, you can see in the blue, yes, you aren't able to go as fast, so we're not able to go as far or go as fast when it comes to doing maximal testing, but our maximal heart rate is going to be a little bit higher because we've got a smaller heart. And heart muscle fiber, we can effectively only fill so quickly and we can only pump so quickly. So that's why you see like rodents have a resting heart rate of like 200 to 300 beats per minute. And then something like a blue whale is going to have a resting heart rate that's going to be like just barely in the double digits. So we're going to see our resting heart rate go down thanks to training because we're going to have not just that bigger heart, but we're going to have a greater amount of parasympathetic tone, aka we're going to be more relaxed. The body doesn't have to work as hard at rest because the heart's literally in better condition. And so if we take somebody who's sedentary and then we start having them work out, we can see that resting heart rate literally going down about one beat per minute per week. And I've heard of examples. It was actually through Cal Dietz and his triphasic stuff, though I get to see him publish anything off of it, saying that he could get some of his hockey athletes to actually get their resting heart rate to drop down 2 or 3 beats or more than 2 or 3 beats per minute per week when they were doing maximal eccentric and isometric loading because of its effect on the cardiovascular system. Now, your really highly trained athletes, you might even literally see resting heart rates that are less than 30 beats per minute. Now, when it comes to exercise, we are going to be able to do the same submaximal exercise output, so it's going to be wattage, speed, etc., at a lower heart rate when we get to be in better condition. Now, this always depends on obviously how great a shape we were in to start, how adaptable we are, but we're going to see improvements. When we're talking about maximal heart rate, it's probably going to stay the same, so like true like full output, or maybe go down a little bit. However, we're going to still be able to perform better. Now, one of the reasons why we might see this decrease is because we literally need more time to fill that heart maximally for each beat. And so once we go up to a certain speed, we literally cannot let the heart relax, refill, and pump so that we're going to have really optimal stroke volume. In fact, your heart actually becomes a little less efficient with stroke volume once we get up to maximal heart rates because we've got so little time for the heart to fill with blood. Now, Your heart rate recovery period is how long it's going to take you after you finish exercise for your heart rate to get back to its resting rate. The better condition you are in, the faster you're going to return to that resting heart rate. So this can be a good way that we get an idea of how good of a shape an athlete is in. So have them do a maximal exercise and then see how long it takes for the heart rate to come back to baseline. In fact, this is a great way to condition large teams if you have the availability to do so, because you literally can go ahead and get the heart rate information on your athletes. And then depending on how good a condition they are, you can make them do more work or make them do less work. So they're actually taxing their body at the rate at which their body can recover from the effort and go at it again. Now, if we're training at altitude, we're going to see a slower heart rate recovery because that partial pressure of oxygen is lower, which we're going to get into more at the end of this class, like literally like later on in the term. And if you're training in very hot environments, because we have a greater amount of cardiac output that needs to go to the skin in order for us to thermoregulate, we're going to see a much slower heart rate recovery after exercise. So we're not trying to do this to compare athlete A to athlete B, so to speak. Instead, we compare this to yourself. So we see, does your heart rate actually recover faster after exercise when you get to be in better condition compared to when you first started training? So here's that example when it comes to that heart rate recovery, where have an athlete go out and do 4 minutes of essentially maximal exercise, and then give them a 3-minute recovery, and notice after training the individual that happens to be, or when they're more well trained, they're going to recover far faster. Now, that cardiac output, because we don't see much of a change in that heart rate, but we see a change in that stroke volume, we're going to see it being able to go higher and higher. So notice the cardiac output is the same at all of those submaximal levels. Once we start getting close to max, that's when we see the split between the pre-training and the post-training abilities, because literally their heart now can pump more blood per minute. And because of this, they're obviously going to be able to go and perform at a higher level than they would have been able to previously. Now, we're going to see that we're able to increase blood flow with training because we're literally going to increase the amount of capillaries we have around our muscle fibers. Now, this is going to be through branching and intussusception, which we're going to have you guys get into in, well, I guess we got enough people tonight, so we're actually going to have you guys do some group activities if everyone has the ability to participate like that, but I'm not quite sure if we have that type of functionality. Now, we're also going to do a better job of vasodilating the capillaries, specifically the arterioles feeding the capillaries of the muscles we're training. And so we're going to do a better job of sending the blood where it needs to be. Now, we're also going to increase our blood volume by first increasing the amount of plasma we have, and then increasing the amount of hematocrit, aka our red blood cells that we have. Now, blood pressure in general is going to typically go down a little bit as we get to be in better and better shape. At maximal work rate, we're still going to have a much higher blood pressure, but it's the advantages that we're going to see at rest, and especially for individuals that are borderline or have hypertension. So aerobic training is a really good modality to use to help improve cardiovascular outcomes. And whenever we're doing things like really heavy lifting, we're going to see super high blood pressures because of that Valsalva maneuver and that massive amount of intra-abdominal pressure that they're creating against that closed glottis, which is going to give us those blood pressures that can be through the roof, for lack of a better term. Now, when it comes to the blood and adapting with training, as soon as you start working out from being sedentary, we're going to immediately see an increase in our plasma volume. This is because we're going to have an increased amount of albumin and some of the ions that is literally going to pull more fluid into the blood. The greater blood volume in turn is going to allow our heart to fill essentially at a faster rate, which in turn is going to allow us to have a better cardiac output. Now, it's after about 1 full month of hard training that, thanks to the hormone erythropoietin, we are now going to start increasing our amount of red blood cells. And when we increase the amount of red blood cells, we're still not going to have the same hematocrit as we had pre-training, but it's going to be improved, which in turn is going to give us much better aerobic performance than we would have had previously, because now the heart's able to fill even better, along with that greater amount of filling. We're going to have those changes in pressure gradients, which in turn is going to allow the heart to pump more blood per beat. So here is that example, guys, where you see most of the changes we're getting is actually going to be because of increases in our plasma volume. We do have a slight increase in our hematocrit by increasing the amount of red blood cells that we have, but it's not that massive. And that's okay. Like, we're going to be able to increase our total amount of red blood cell number, notice, from post-training, but the amount, as far as the fraction it's going to make up in our total blood volume, is actually going to go down. Now, as long as your hematocrit is between 40 and 45%, you're fine. Once we're getting over 50, now we're talking about some really, really thick blood, and you probably want to go donate some red blood cells because that's going to help bring you back down. And obviously, when we get under 40, now we're talking about anemia. We have a diminished oxygen carrying capacity in the blood, and that can obviously have its own myriad of issues if we're not careful. So endurance training, and especially hard endurance training, is going to increase that blood volume. And this is going to be due mostly to the increase in plasma volume, which is going to occur nearly immediately within the first week. After a longer period of time, we're going to increase our total amount of red blood cells. And in turn, this is going to go ahead and have us have a total amount of blood volume, but still a lower hematocrit than when we started. Now, the nice thing is we also have a lower blood viscosity. Since our hematocrit is lower, our blood is a little bit more effectively watery, which is going to allow us to pump that blood around the body with less resistance. And when we have less resistance to that flow, in turn, we're going to have better oxygen delivery to those tissues. And these changes in blood are going to be related to the changes that we're going to see in both our stroke volume increasing and our VO2 max also increasing. So when it comes to these changes, we're going to see an increase in both the size and the wall thickness of the left ventricle. Now, we see an increase in size in the right ventricle, but it's not going to obviously be as much because it doesn't have to work against as near as much pressure as the left ventricle. We're going to see changes in all of our heart rates from resting to maximal. Sorry?
I got a question. You said the left ventricle size is going to increase in thickness. When does it not increase? It's only when it's resting?
Okay, so when we're talking about this increase, we're talking about chronic changes. So it's not like you start working out and then all of a sudden your heart gets swollen.
Okay.
The key is from doing all of this aerobic work over time, just like you lift weights and your muscles get bigger, the same thing happens with your heart. If you do enough work intelligently, you're going to see your heart literally hypertrophies a little bit. So it gets a bit bigger, gets a bit stronger. Does that make sense?
Yeah.
Cool. So we're going to have much better stroke volumes from all around the board. We're going to see our maximal heart rate is going to stay the same, maybe go down a little bit just because the heart's bigger and it can only contract at a finite speed. We're going to have way better cardiac output, and we're going to do a better job of sending that blood where it needs to be. And yeah, we had the increase in blood volume, technically a smaller percentage of red blood cells, but that's still going to help us with our performance. And our resting blood pressure isn't going to change too much. It might go down a little bit. And when we're talking about during exercise, it's probably going to go down or be a little bit lower than it was pre-training, simply because we don't have to work as hard to maintain the same outputs. But once we get up to max, we're still going to be at max. Now, outside of just thinking about the ability to ship blood around the body, we need to think about a couple other components. The lactate threshold, and that's the point of which, remember the drain analogy and the filling the tub. So our lactate threshold is the point of which we're filling the tub faster than the drain is allowing it to go out the bottom. Now, we are going to effectively be able to increase the size of our drain with training. And so we're going to be able to go for longer before it's going to start to accumulate, as far as we're going to be able to ramp up our production a little bit higher, which is good. Our respiratory exchange ratio is going to be effectively the amount of oxygen we're taking in and how much carbon dioxide we're giving off, actually inverted. And whenever we take in a greater amount of oxygen relative to the carbon dioxide on top, we're going to be utilizing more fats as fuels. When we're going about that 1-to-1 ratio, that's when we're talking about we're going to be utilizing, on average, aerobic metabolism. And we're going to find that we're going to be able to use fats for longer periods of time and up to higher intensities of that VO2 max. Now, our total amount of oxygen we're going to use is going to be probably the same. It might be a little bit higher, Russ, just because we've got maybe more muscle mass and more tissue to take care of. And when we start exercising, it's probably going to stay about the same as it would have been before, maybe go down a little bit because we're more efficient. And what we're going to find is it's definitely going to be increased when we talk about the max. And what's interesting is thanks to genetics, sadly enough, there's some people that are non-responders to aerobic training. So, or very, very low responders. So they can do a lot of work and barely get any changes in their VO2 max. But other folks are high responders, and getting them to do aerobic style work, they can see massive increases in their aerobic capacity. Now, a number of things are obviously going to influence our VO2 max. Obviously, how good a shape we're in, good old who your parents are, how old are you? And once we're talking about getting well into our 40s, our aerobic capacity is simply going to start to decline. It's one of those things that tends to be related more to your activity levels, but you're also going to see a slight decrease in just the physiological function in your body. In general, women tend to be a little bit lower than men when we're comparing the trained men to trained women, and it seems to be mostly just due to just differences in body fat, lean body mass. And the more specific we are with our training, the better we're going to do with a VO2 max. So if you like to cycle, you're going to be really good at a bike VO2 max. If you like to run, you're going to be good at a running VO2 max. If you like to swim, you're going to be good at a swimming VO2 max. If we have you try to do something that you're not used to, you're actually going to be performing far more poorly than one would have expected. So when we look at the ability for individuals to maintain or improve that VO2 max over time, notice doesn't matter which age we're talking about working with, when you stop training, your performance goes down, plain and simple. But notice the group that was training hard from effectively their early 40s to their early 50s, they were still actually able to slightly increase their VO2 max. The individuals that were still maintaining their training intensity from their mid 50s to their mid 60s stayed about the same. It was the group when we're starting to get in from our effective 60s to our 70s, that's where we're going to start to see that decline more in performance, simply because, once again, physiologically, the body starts to run down. But the nice thing with aerobic training is that's one of those things that you can pick up nearly at any single point in your life and be able to make some pretty considerable amounts of progress. But depending on how well trained you are in any area, you're going to always reserve or have a certain amount of adaptability all the way until the end of the road. Now, I made the mention of specificity earlier. This graph is a great example of it, where we have just uphill treadmill running as a way to do a VO2 max. And the other side, we have the actual sport-specific activity. Notice there were no athletes that did better on the uphill running than they did on their sport-specific activity. And in fact, notice the one gentleman, the elite rower, that had a VO2 max on the rower of 75, but when he was doing uphill treadmill running, couldn't even get over 65. So once again, our ability to express that total aerobic capacity is always going to come down to our specificity of how we train. Now, if you understand this slide, you understand the aerobic system and how it's going to work, how we're going to be developing one side and then the other, and how they're going to effectively all work together in order to enhance our performance. So this is something that I want you guys to take some time, go through, and then next time when we meet, we're going to talk through this at length. But effectively, every single modification we've talked about so far of the different ways we're going to be changing the body and the cardiovascular system through the training, this is every single piece of it. And so if you understand how this flow chart works, you understand the major points of how our aerobic system is going to adapt to training. So let's talk about breathing, okay? Now, we're just going to talk about, obviously, how we're able to get oxygen to our tissues, how we're going to get rid of CO2, what's going on with respiration and gas exchange, which are technically two separate things, and how we're going to help regulate this. Now, this is going to let us know about how we obviously care about aerobic capacity when it comes to performance, how it can potentially limit performance, but it's very rare for most people, and how it's going to help us control for our pH system that we're trying to maintain in our body. So what we're going to find is pulmonary ventilation, guys, is the actual act of breathing in and breathing out. Pulmonary diffusion is going to be where we're actually exchanging oxygen into the bloodstream and carbon dioxide out of it. Okay, here we have the gentleman by the name of Wim Hof, and he's sometimes referred to as the Iceman. The things that this guy does with essentially breath work and tapping in a little bit into his own physiology through breathing at different cadences is fascinating. If you guys are interested, please take a look at some of his stuff. What he's doing is just, it's really, really interesting and mildly terrifying. Now, we have this system where we're going to breathe in and breathe out. Air is going to come through our nasal cavity, through our mouth, through the pharynx, larynx, down the trachea, through the bronchi, into the bronchioles, and then eventually into the individual alveoli that are going to be wrapped in capillaries where we're actually going to have the true gas exchange. So we always have this anatomical dead space, this point at which where air has to travel through the nasal cavity, down the pharynx, down the larynx, down the trachea. That's always going to have wasted air. So the first part of every breath you exhale was air that you were not able to exchange at all with the environment. And then the last part, or the first part that you inhale, was the air that was already in your trachea that you'd already gas exchanged, so it's not going to be as oxygenated as you wanted. So we're going to find at rest, we're going to inspire by contracting our diaphragm, which pulls our lungs downwards. And then when we exhale, we're simply going to relax our diaphragm, which brings it back up. And what we're doing is we're creating a pressure gradient. So when we inhale, we're creating a vacuum. We have lower pressure inside of our lungs than outside the environment that pulls air into our body. When we exhale, our diaphragm moves up, which creates a hyper pressurized lung, which is going to get air out of our lungs and into the environment. Now, if you push a little further after a normal exhale, you're going to be using the muscles of your intercostals. You're going to be using your abs, perhaps your lats, and a little bit of your quadratus lumborum to get a little bit of extra air out of the lungs. When you're taking in a really deep breath, you're going to be contracting your external intercostal muscles, along with you're going to be contracting your scalenes, along with your SCM, and maybe even using things like your pec minor if you're really hurting to go ahead and help lift that rib cage and expand it. So we're going to be able to get more air in each breath. Now, this is going to be in pulmonary infusion where we're actually going to go ahead and replenish the amount of oxygen that we have so we can maintain aerobic energy systems, because it turns out that's how your brain works and that's how your heart works. There always need to be aerobic. Obviously, we can hold our breath for decent periods of time, but we still want to make sure that we have enough oxygenation to our tissues. Now, we're going to be removing carbon dioxide, and this is going across that very, very thin respiratory membrane between our alveolar cells, which are essentially smashed flat, and then the capillaries on the other side. So because of how thin they are, this allows for a lot of gas exchange to occur because it doesn't have to go across a very large distance. So here's an example of one alveoli wrapped around by a number of capillaries so that we're going to get a huge amount of gas exchange. Now, when it comes to gases, there's a number of laws you need to understand. The first of which is what's known as Dalton's Law, which is the total pressure of every gas in the air is going, or of the gases, is equal to the sum of the individual gases. Meaning, the air that we're breathing in right now is about 20.93% oxygen, about 0.03% carbon dioxide, and most of the rest of that is nitrogen. So when we multiply the total air pressure, which say 760 millimeters mercury, that's the typical barometric pressure, by each of those percentages, that gives us the partial pressure of each of those gases. The reason we care about the partial pressures of those gases is because that lends itself into Henry's law, which is gases are going to dissolve into liquids in proportion to their partial pressures, depending on how soluble they are going into those fluids and on the temperature. So carbon dioxide has a huge solubility, so it doesn't need a very large partial pressure to effectively get it to enter your bloodstream or effectively leave it. Whereas oxygen needs a much larger gradient in order to go ahead and effectively push it into our bloodstream because of its solubility is much different. So nitrogen is at 79.04. We multiply that by 760 millimeters mercury, which gives us 600.7 millimeters mercury, and you can follow the math as it is from there. So once we go ahead and put all those together, it's going to give us information as to how well we're going to get it to diffuse across our respiratory membrane. And remember, the bigger the difference between the two, along with a greater propensity for it to go ahead and be more soluble, we're going to get better gas exchange. So that partial pressure of oxygen, you guys remember just a couple slides ago, was much higher than 105. The reason it goes down is because our lungs, the alveoli, are very moist. And so the water H2O partial pressure is considerable. So hence you see the partial pressure of oxygen dropping down to 105. Now, when that blood is coming from our right ventricle being pumped into our pulmonary artery and then into the capillaries around those alveoli, it typically has a partial pressure of oxygen of only about 40. And it can be even lower than that, especially when we're doing maximal exercise. From there, the partial pressure of oxygen in the air inside of your alveoli is 105, and that's going to go ahead and allow it to come all the way up to 100 by the time it typically is leaving those capillaries. And when it comes to carbon dioxide, you can say we're going from 46 to 40. Now that's going to go ahead and go back to the left side of the heart, be pumped out to the body, and once we get to the tissues, we're going to have whatever amount of oxygen taking up we need. So the exercising muscles, they might take the partial pressure of oxygen all the way down to 0 around it, where they're using every last molecule of oxygen available. Whereas other parts of the body where that oxygen or that the blood's being delivered to is not as metabolically active, so it's not extracting that much. That's why we see that the systemic veins, partial pressure of oxygen being 40 and partial pressure of carbon dioxide being 46, because it all averages it out when it all mixes back together, specifically when we get back to the vena cava. So when we're talking about these partial pressures, we've got dry air, okay? So we have that 100% total, then we've got what, multiplying that out by the percentage into dry air. Then when we go to alveolar air, notice guys, we see that partial pressure of water jumping up massively, which is really what's decreasing our partial pressure of oxygen, and carbon dioxide is coming up simply because it's naturally being released. And you also see a dip in the partial pressure of nitrogen. And then venous blood, we still see that same type of shifting. So we get a basic idea of the total diffusion gradient to get each of those out of the system. So pulmonary diffusion is how we are going to actually be able to exchange gases across the alveoli, and from the alveoli, or from the air to the blood and the blood to the air. Yeehaw. And how much we're going to get to this exchange depends on that partial pressure. So if you're breathing air that has a higher amount of carbon dioxide in it than you have effectively in your lungs, you're not going to be able to get rid of any carbon dioxide. Now, that's not necessarily going to kill you immediately, but it is a bad thing, and that would literally be breathing inside of a burning building. And it turns out that's not going to be a good thing for your overall health. Now, these gases are going to diffuse thanks to those pressure gradients. We're always going from high to low, just like diffusion when we're talking about solutes. And so as we start exercising, we're going to see a greater diffusion capacity of oxygen because we're going to extract more from the blood. We're not necessarily going to be able to carry more, but we're going to be able to extract more. And whereas carbon dioxide, we're going to never really see that big of a gradient because it's so easy for it to go and exchange. We don't have to have a massive gradient to get rid of it. Now, oxygen, for the most part, about 98% of it or more is being carried around, bound into hemoglobin, which is inside of your red blood cells. Now, one red blood cell has probably millions of hemoglobin proteins inside of it, and you probably have billions of red blood cells in you. Now, what we're going to find is when we increase the pH, when we decrease the pH, we become more acidic. Okay, so that's the increased amount of protons. Or we increase the temperature, we are going to much more rapidly unload oxygen from hemoglobin. And that's a good thing because hard exercising muscle has a lower pH thanks to anaerobic metabolism and a higher temperature thanks to the metabolic work. And because of this, we're going to do a better job of freeing up oxygen at the muscles because we're going to much more readily unload it. And we're going to find that training in general is going to help with our body's ability to transport this oxygen to the muscle. So we're going to see we've got an increased amount of capillaries, along with we're going to go ahead and have a better job of making sure that we vasodilate so we get better blood flow to them. So this is what's known as an dissociation curve. So at which partial pressures of oxygen, we're going to see that hemoglobin is going to let go of oxygen. So notice when the pH is high and we have low amounts of carbon dioxide, AKA someone that happens to be at complete rest, maybe they're hyperventilating, so they have low partial pressure of carbon dioxide and a high pH, we're not really able to let go of oxygen that easily. Whereas the exact opposite is going to be true when we have that lower pH because we're in a more acidic environment and a higher amount of carbon dioxide, which is exactly the environment you're going to find right next to really hard training muscle. And then you can see that same type of relationship as the temperature increases, and exercising muscle is going to be much warmer than non-exercising muscle. Now, aside from hemoglobin, we also have what's known as myoglobin. Myoglobin is the protein that carries oxygen from the sarcoplasm to the mitochondria inside of our muscle cells. And so notice that myoglobin, for the most part, is always going to be grabbing far harder to oxygen than hemoglobin, because that's a good thing, because effectively what it's doing is taking that oxygen from the hemoglobin, and then it's shipping it over to the mitochondria. And in the mitochondria, you pretty much have nearly zero oxygen available, because as soon as oxygen is in there, it is going to be used as that final electron acceptor at the end of the electron transport chain. So since it's constantly dumping, that's why you see that more tan or peach colored box in the bottom. Since it's constantly unloading to very low partial pressures, you see how it normally has a major difference between hemoglobin and myoglobin, which is a good thing, because it's going to take it from it and put it where it needs to be, so you can use it aerobically for metabolism inside of mitochondria. So our total AVO2 difference gives us an idea of how much oxygen we were able to extract as it went through the body. The greater the AVO2 difference, the greater amount of oxygen we were able to pull out, which means we're going to have had better performance. So notice between the two, you have a much greater AVO2 difference in the exercising muscle on the bottom, as opposed to the muscle that's more at rest at the top, because resting muscle doesn't have that much of a metabolic demand. It's not really doing anything. But maximally exercising muscle is using a lot of energy, and since it's using a lot of energy, it needs a lot of oxygen so it can maintain that energy production through both beta oxidation and the electron transport chain. So there's a number of things that are going to obviously factor into our body's ability to utilize oxygen. One is how much oxygen do we have in the blood? Two is how much blood flow do we have to that area? And then three, what's the actual local conditions inside of the muscle? Do we have everything we need in order to utilize aerobic metabolism? And so we want to make sure that we're always fueling the cells appropriately, but we're also removing the waste products, specifically carbon dioxide. Now, most of it is actually going to be in the form of what's known as bicarbonate ions because of the dissociation, which actually gives us a bit of a buffering effect. Part of it is actually going to bind to hemoglobin after oxygen is left. So it's deoxyhemoglobin, which then has carbon dioxide bound to it, which gives us carboaminohemoglobin. And then that in turn will go ahead and be shifted again once we get all the way back to the wonderful lungs in order to go and let go of it. And about 10% or less is actually how much is going to be truly just dissolved as plain carbon dioxide inside of the blood. And this is going to be obviously of the total proportion of it that we have in general. So our external respiration is that air that we have inside of our body, or outside of our body. The internal is what's going on as far as our actual exchange. So notice, guys, you can see how we're going to have that atmospheric air, the partial pressure of oxygen and carbon dioxide, to where it will then be, thanks to the wonderful water vapor portion, go down for the oxygen, high for the CO2, because we have that gas exchange relatively naturally. And then we're going to put that into our pulmonary veins, goes to the left ventricle, gets pumped around the body, gets extracted massively once we go ahead and get to the capillaries of the specific tissues that are going to use it. It's then going to be returned to the right ventricle, pumped out back into the pulmonary arteries, where it's going to undergo respiration again, and specifically picking up oxygen, dropping off CO2. So we are going to be traveling most of the oxygen in our body bound up to hemoglobin, okay? We're going to see hemoglobin does a better job of unloading oxygen when we happen to have a higher temperature or a lower pH, and that's a good thing. Typically, we're sitting at about 98% saturation, which is more than what our body needs at rest, and it's going to be one of those situations where typically our carrying capacity is rarely a limiting factor during exercise. It is an issue when you have individuals that are at altitude, or you have individuals that happen to be anemic. So they have a lower amount of oxygen carrying capacity inside of their body. Now, CO2 is going to be transported around the blood in the form of bicarbonate ions. And this can be both in the blood plasma or bound to hemoglobin. Okay. And our AVO2 difference is the total amount of oxygen that we're actually able to extract from the bloodstream, from the arterial blood to the venous blood. And this is giving us an idea of how metabolically active those tissues are actually being. And we're going to find that CO2 exchange is a lot like oxygen exchange, except it's going to enter the blood and then leave when we get to the lung, as opposed to enter when we get to the lung and effectively leave when we get to the capillaries, the exercising muscle. Now, what's regulating our breathing rate is a number of different systems. So first we have the higher brain system. If I tell you guys to think about your breathing and breathe normally, you're not going to, because now you're thinking about your breathing, which is naturally going to throw that off. That's fine. We're going to have chemical changes, and specifically it's the chemoreceptors that are letting us know when our pressure of carbon dioxide is increasing. That's actually what's driving a lot of our desire to breathe. We have muscle mechanoreceptors that are showing when we're not getting enough blood flow to the area, specifically just high pressure, a little bit through our hypothalamus, which is, remember from your earlier phys or physiology classes you had, of being the master regulator of homeostasis in the body. And then obviously we can control our breathing. And controlling your breathing is both a good way to help your body relax and also to help your body move into a higher state of arousal if you need to, in order so you can perform. So all of these factors are going to influence our respiration. So first and foremost, the brain itself is going to be a major regulatory factor. How high or low our pH is. If our pH is too low, we're going to breathe harder. If it's higher, we're not going to breathe as much. If we have greater amounts of CO2, we're going to be breathing faster. If we have lower amounts of CO2, we're going to be breathing slower. In fact, you can purposely slow down your breathing, which is going to feel like you need to breathe faster. But if you actually looked at your saturation points of oxygen, you're going to be absolutely fine. We have other chemoreceptors that are going to get into our body's understanding of the total pressure of also that oxygen component, how much our muscles are contracting, what's going on with our actual breathing musculature, and also our lungs themselves are going to get information. The lungs never want to be overstretched. If you overstretch your lungs, you're going to have some massive, massive problems. And so this is why you guys might find it difficult to breathe if you have your head out the window, like when you're driving a car at high speeds or something, where you just have a lot of air blowing in your face. It's uncomfortable, and you have to consciously think about breathing in slowly because of those stretch receptors in your lungs, because once again, you can't overstretch them. You just destroy them if you try and do something like that. So as you would expect, you're going to breathe in a total or greater total amount of oxygen as you increase your exercise output. And it tends to be a relatively linear relationship until we hit the point of which we are going to run into what's known as the ventilatory threshold. And this is going to be where your breathing rate is going to go up way faster than your actual metabolic demand. And that's actually a last-ditch effort of your body to help buffer out through more bicarbonate the extra amount of protons that are coming into your bloodstream thanks to anaerobic metabolism being utilized to keep up your work rate. Now, there's a number of different breathing problems you have during exercise. Dyspnea is going to be one of those, where it's just shortness of breath. And this is where our body is not able to regulate appropriately. And often this is going to be more due to individuals that are just in really poor condition, because respiratory muscles are muscles like any other. And if they are in very bad condition, you are literally not going to be able to breathe as well as one would hope. You can also hyperventilate, where you're going to be breathing way faster than you need to, which is going to cause your pH to go super high, which is actually going to do a lot of bad things to your body, because it turns out we want to have our pH within certain physiological ranges. Now, the Valsalva maneuver is going to be that bearing down you're going to do against a closed glottis whenever you're trying to lift heavy weights so you don't hurt yourself. If you're young, if you're healthy, if you've got relatively good vasculature, you don't have any insults to those systems, it's absolutely safe and fine. If you're old and you got some miles on the automobile and we have some issues, you don't want to play around with this, because this is something that can cause a lot of issues in a short period of time if you're not careful. Now, when we're looking at the total amount of oxygen we're breathing in relative to how much ventilation we're getting in, this was known as a ventilatory equivalent. this lets us know effectively how efficient is our breathing. So when we're at rest, we're going to see for every 23 to 28 liters of air, we're going to go ahead and get ourselves about 1 liter of oxygen. At maximal exercise, we're actually going to be looking at more like 30 liters of air per liter of oxygen, because we know we've become more inefficient because we're looking to try and have that buffering component, and we don't have as much time to allow for optimal gas exchange in those capillaries. Now, the ventilatory break point is going to be the point at which where we're going to see our breathing rate take a turn and go far faster than you'd expect. For most folks, it's going to be typically in about 55 to 70% of their VO max where it's going to occur. Super high level athletes, it might not happen until they get into the 90+% of their VO2 max, because this is where we're literally seeing the point where our CO2 levels are rising and our pH is starting to lower. So the body is naturally going to try to breathe harder for you to go ahead and try to buffer that out. And this is where you get to what's known as the talk test. And that if you're working out with somebody when they're no longer able to hold a conversation with you is a great indicator that they are aerobically not able to keep up the work output that they're being asked to do, which in turn is going to be causing them to have the accumulation of those metabolic byproducts. And the accumulation of those metabolic byproducts in turn are effectively going to let you know that fatigue is coming. Now, how soon it comes and how hard it hits them, that's very much on an individual by individual basis, but the clock is ticking and it's ticking down for them. So this is that example when we're looking at that efficiency of breathing. And notice, guys, we're going to see that point where we're going to see that really big uptick in our ventilation compared to the velocity at which it was going up earlier. And when you guys have been doing the VO2 max labs, look for this now. You'll see it, especially whenever you're having people do these maxes, the point of which where they really do have that inflection. And it's typically right before you would actually start to get a consistent increase in blood lactate levels. So that anaerobic threshold is what I was referring to with that lactate threshold. And this is going to be the which we're going to have to keep our performance up with anaerobic metabolism. We cannot keep it up with aerobic performance anymore. And this tends to be really close to the lactate threshold, and also very close in the ventilatory threshold came right before that. And this is useful because it's going to let us know when, once again, we're not able to utilize just our aerobic glycolysis and beta oxidation to keep up our work rate. We're having to tap into enough of anaerobic metabolism that we're going to have the accumulation of metabolic byproducts, which once they accumulate to certain levels, pH drops low enough, and literally the enzymes and glycolysis don't work right anymore, so you can't physically keep up that work output anymore if you even wanted to. So when we're looking at that total ventilation divided by CO2, notice how you're actually going to see that carbon dioxide levels actually going down, whereas the oxygen in and of itself is going to be going up. And that is our indicator of when someone's hit that ventilatory threshold. So to say that again, guys, what we're seeing is we're actually getting rid of less CO2 per breath, we're technically more efficient with carbon dioxide, but we're less efficient with oxygen because we're using it as a buffering component. So our respiratory systems in our brain are telling us how much we need to breathe at rest. Now, we can have conscious control of that, but that's another thing. We have chemoreceptors that are going to let us know, thanks to carbon dioxide levels and proton concentrations, of what we need to go ahead and do with our breathing rate. And if the pH, the hydrogen ion concentration goes high enough, aka our pH goes low enough, it's going to actually tell our body to throw up because it's going to think that we're poisoned. And that's why people can vomit from doing really hard things like gassers, 300-yard shuttles, 400-meter repeats. And we're going to see that our ventilation is going to increase thanks to that muscle activity. We're going to see the changes in temperature and the chemical components of the blood, letting the body know, like, hey, we need to be ready to go. Now, there are some potential issues we can have with breathing with exercise, and that's very much so something to be aware of and how it's going to show. We're going to see that we're going to breathe at whatever rate we need to in order for the exercise we're doing. So if we all go for a walk, and I mean, not just the individuals listening today, but if we had anywhere from a high level track and field athlete to, just a very, very out of shape, overweight individual. We can all be walking at, say, 3.5 miles an hour. So you're going at a decent clip. The marathoners are going to be bored. Whereas the people that are really big and out of shape, they're going to be breathing at a massive rate, because for them, that is a very high level of output. And because of that, their ventilatory level is going to express that, because it's very much so individual to individuals. And so we're going to be looking for that ventilatory break point, because it gives us good information as for how long we can stay super efficient with those energy systems to keep up our performance. And our anaerobic threshold is going to be where we're going to see that point where we have that inflection, along with the VCO2 is going to stay the same, maybe go down a little bit depending on the individual. And what's really fascinating is when we're exercising, about 15% of the total amount of oxygen we're consuming is literally being used by your diaphragm and all of your other muscles that are involved in respiration, because it turns out we got to get that oxygen in the body. And they're pretty good at not fatiguing out, but like anything else, there's always going to be limits to their functionality. So it's relatively rare, but you can have such well-trained aerobic athletes that literally their limiting factor for their performance is actually going to be their pulmonary ventilation. They literally, their diaphragm, their intercostals, their scalenes, their SCM, all of them are in great shape, but not great enough shape compared to the sheer aerobic work that their skeletal muscles can do and how much blood their heart effectively can pump if it had enough oxygen being carried in it. Now, when it comes to our actual resistance to gas exchange, it's very rare in individuals that are healthy, but it obviously can happen with certain types of obstructive respiratory disorders, aka when you talk about people with asthma, where they're not going to be able to keep up or maintain higher intensities because it's the equivalent of trying to breathe through a straw. I know a number of us have been riding the struggle bus a little bit while wearing masks when exercising. It does make things slightly more difficult, but it isn't something that should take down anyone who's actually in shape. If you're in really bad shape, if you're unhealthy, yeah, the mask might be a little too much, but in the first place, we had some other issues we need to worry about. So we're going to find that when that pH goes down low enough, we're literally not going to be able to get our muscles to contract anymore, because we're not just having issues with actin and myosin cross-bridging, we're having literally issues with building more ATP. So our breathing actually helps with regulating this, because it allows us to get rid of the CO2, which, remember guys, is part of that bicarbonate, which in turn is going to work as a buffering component. And so what we're going to find is these bicarbonate ions, the greater amount we have, are going to actually help with dealing with proton accumulation in the blood. So we're going to find that we have those relative limits that we're looking at for our pH with our blood when we're at rest. Now, our muscle pH is going to be a little bit lower, but anytime we get that pH under 6.9 or we get that muscle pH under that 6.63, you literally cannot keep going. Your brain's going to shut you down in the arterial blood pH. Your muscles are going to shut down when it comes to their actual pH levels, because, once again, failure of contractility, failure of ATP production, either way, you literally can't make that muscle contract anymore if you wanted to. Now, when I say buffers, guys, you have to keep in mind when things are in solution, we are going to see a bunch of free-floating ions. So if you just add hydrochloride to a simple salt water solution, sodium and chloride, you've got a little protons floating there. Now, if you have bicarbonate inside of water and you add hydrochloric acid, notice that proton is now being taken up into creating more carbonic acid, which is going to effectively allow for some of those protons to be pulled out of circulation. And that's what I mean by a buffering capacity. So if we have a huge amount of bicarbonate, we're going to be able to essentially bond a bunch of those free-floating hydrogens to it, which in turn is not going to cause them to actually decrease your pH, which is, pH is literally looking at a inverse log of the total amount of protons you have in a given solution. So when we're talking about bicarbonate, we take that carbon dioxide and water, we're then going to have carbonic acid, and then we have hydrochloride. So whenever we add in lactic acid, we're seeing a shift to the left here. in that we're going to see that carbonic acid, we're going to see that CO2. When we're going to the right, on the other hand, that's where we're going to, pardon me, when we're going to the right, that's when you're going to be causing it because you vomited, which is going to help drop your pH, which is not a pleasant thing it's an effective methodology, but it's not something that you're going to train your athletes for. So as we increase our total amount of carbon dioxide, we are in turn going to be creating more of that carbonic acid. That carbonic acid is going to dissociate into both hydrogen and bicarbonate, which in turn is going to bring our pH down. This in turn is going to tell our medulla oblongata to make us breathe more, increase both the breathing rate and the depth of those breaths. And this in turn is going to get rid of more carbon dioxide, which is going to help bring our pH back up and hopefully allow us to keep up that work output for a longer period of time. Now, I touched on briefly before a little bit about our heart rate and how that's going to be being modulated through parasympathetic and sympathetic tone. Now, a concept of this is what's known as heart rate variability. And so if you're to think of your heart rate as a metronome, it's never a perfect cadence. There's always a little bit of deviation. And the greater amount of deviation we have, so like if we were to look at your heartbeat over an entire minute, so say your resting heart rate is 60 beats per minute, there might be points at which your heart rate speed was closer to more like 59 beats per minute and other points where it was closer to 61 beats per minute. This is heart rate variability and this is normal. In fact, this is something that's individualized. So some folks naturally have greater variability, some people have less, but it's a pretty good predictor of recovery because when we add in sympathetic nervous system tone, so this is a greater amount of epinephrine in the bloodstream, we see a greater amount of regularity with our heart rate. When we have a greater amount of parasympathetic tone because of the natural breathing in, which creates the vacuum, which is going to in turn allow for more vagal tone, and then breathing out, which is going to cause compression in the chest, which is going to be the opposite on the vagal tone. Breathing in is going to pressurize your vagal nerve, which in turn is going to inhibit it. Breathing out is going to remove pressure from your vagal nerve, which in turn is going to allow it to be more stimulated. So we should see a natural changing in the cadence of the heart through your breath cycle. When you've got a greater amount of heart rate variability, it's a really good indicator of how well recovered you are. So when you're working with athletes, it's not just important to look at the resting heart rate. If your resting heart rate is elevated today from where it was yesterday, that's not a good thing as long as you've maintained hydration levels, diet, you're not suddenly at altitude or in a very warm room. That's telling us things about your body is not as recovered as we hope. Whereas if you happen to have a greater amount of heart rate variability and a lower resting heart rate, that's letting us know that your body's even more relaxed, it's even more recovered, and in theory, you're ready to really train hard that day. So this is a science or part of the science that's still being developed. And keep in mind, guys, it's a lot of different apps and wellness systems are trying to develop really good ways of saying this is how you actually track your HRV and this is when you're really ready to train and this is when you're not. But it's important to keep in mind it's always based on the individual. So we're not trying to make sweeping statements because individual A's numbers were this and individual B's numbers were this. We're not saying that makes A healthier than B. Instead, it's important to track your individual heart rate variability and resting heart rate, or your athlete's resting heart rate and resting heart rate variability, and seeing how those change with training. And that's going to give us an indicator of how well recovered someone happens to be. So the last thing are you guys all in a situation where you guys could actually kind of unmute yourself and talk about a basic concept and kind of work together on something?
Yep, I can.
Okay, Jabari, how about you, bud?
Yeah.
Okay, and I'm guessing Alex is still at good old band practice, so he's not able to go ahead and chime in. So Jabari and Ihor, you guys are going to be working together, and Alex, I'll have you try your best, but we're going to go ahead and have you guys do. We're going to have you guys do for 5 minutes. You guys are going to work together, and can you guys read this right here on my slide notes?
Yeah.
Okay, so there's natural limits to, in theory, how big a muscle can be. Now, there's a number of arguments about what those are. And the ones that I want you guys to go ahead, and like I said, spend about 5 minutes researching it. I want you to go ahead and bring up what's known as myonuclear domains, okay? And so, Yehor, I'm going to have you look into that.
Okay.
Corey, you are going to look into capillary distance. And that's going to be essentially capillary density is really what we're talking about. So how that plays into limits to how big individual muscle fibers can be. Same thing, Yehor. The myonuclear domain is based upon how big an individual muscle can be, okay? And then, Alex, if you're able to, I'll have you go into mitochondrial limits if you're able, otherwise it's okay. And we're gonna give you guys 5 minutes to research on your own, and then we're gonna talk about it, and I'm gonna help you guys through it. So, sound good?
Yeah.
All right, guys, so I'm gonna go ahead and I'm gonna click stop recording.